afterwards. If there's something urgent, let me know ahead of time, and I'm glad to interrupt for that. Um, when I start with the title of Healing Healthcare, it's because of the fact that I think we've got a very sick healthcare system, very unfortunately a sick healthcare system. Why our healthcare system is sick? Affordable Care Act covered more people, but it didn't fix the problems, and it's not more affordable than it was in the past. It cut the number of uninsured by half, which is a huge step forward, but fundamentally it didn't change the way the system works. When I say the healthcare system is sick, how can I say that? Well, we have some of the best medical providers and technology and everything in the world, but the worst system for accessing it and paying for the care, which means a lot of people who the care is meant for can't possibly access it. And remember Alex Smith, I don't have to mention that name too much, but he was a 26-year-old Minnesotan who lost his life. A couple months after he lost his parents' health care coverage because he had diabetes, couldn't afford the health care coverage. His mom said he had about $1,100 in his bank account. When he tried to go to the pharmacy to get it, it was $1,400. He died a couple of days later. Our healthcare system is sick. Yes, coronavirus shows how sick it is. It was a problem already for many people. Now it's become front and center of the nation's attention as part of the coronavirus because it's magnified all the problems and it shows it's everywhere. Pandemic exposes flaws in the system. People don't get the care they need because of cost, copays, deductibles, lack of coverage, poor coverage. All those things create barriers, and they've been intentionally added to the system. We've added copays and deductibles and networks and so on. Why? To create barriers so people don't use so much care. But it's a bad idea, and we see that particularly during the pandemic. The second problem I'll say it exposes is we don't have a logical healthcare system. Nobody's in charge of planning. No one's in charge of coordinating services. If you look at the problems rural hospitals are having, that's hugely available there because they've closed in Albert Lea and Fairmont, Minnesota. They've closed hospitals. Why? Not because there was no need in those communities, but because it didn't fit in Mayo Clinic's business plan, and Mayo Clinic had bought up those hospitals. That's the way the system works. You buy up things, you make decisions based on your business interests, not the needs. But no one's in charge of coordinating it. If there's a shortage of primary care docs, if there's a surplus of other kind of doctors, there's a lack of PPE equipment and so on, nobody's in charge of that. And that's what we're having nationally because the Trump administration has refused to take charge, partly perhaps to blame governors, but whatever, nobody's in charge. The next flaw I'll say is that profitability is driving our system, not public health. One governor said that hospitals and states are in what looks like an eBay bidding war to get personal protective equipment and test kits and ventilators. It said Montana claimed they were outbid by the federal government. Arkansas was trying to purchase 500 ventilators when another state beat them out, offering twice as much money. Middlemen who didn't build the machines, didn't make the masks, are the ones making the best profits in this thing. Even during a pandemic, we have people trying to profiteer off this, and there's no logical system to negotiate prices, so it just becomes a price bidding war. Big Pharma has actually made sure that the legislation passed in Congress to help facilitate getting vaccines. They got it so that Congress took out any limitations on price gouging, prohibiting them from charging unconscionable prices. They've made sure that that was not included in any legislation. So even though we as taxpayers are helping fund the development of vaccines, which are urgently needed, and we do need expertise from the pharmaceutical companies as well as from government researchers, they would be allowed to charge whatever they can get away with. And frankly, with something like COVID vaccine, you can picture people would pay a lot of money for that. And so the price gouging, everything else, it's profitability driving the system, not public health, which it should be. Another one I'll mention, the last one I'll mention the flaws. It mentions there are plenty of them, but bureaucratic paperwork from insurance and billing interferes with medical workers providing care. It's one thing if a nurse in a hospital has to record, she gave you a test for this, or she gave you this many units of some medicine or something. It's one thing if doctor or nurse has to record those things for your medical charts, but they're spending all their time recording it for billing. The hospitals have more billing clerks in a lot of cases than they have beds in the hospital. During the pandemic, there have been some efforts to at least temporarily reduce the prior authorization where a doctor has to get permission from your insurance company before they give you a certain treatment. This is getting in the way. It's gumming up the doctors and nurses and medical providers' work. And so they're at least temporarily trying to change it. Pandemic exposes all these flaws. These flaws would be fixed if we had a common sense healthcare plan. Our Minnesota health plan or a Medicare for all system will not prevent people from getting sick. I mean, it will prevent some illness. If you have a good public health system, you can prevent a lot of illness. You can prevent diabetes. You can prevent lots of types of cancer, but it doesn't stop a pandemic from occurring. What it does do is better coordinate the providers and supplies so you can be ready quickly. You can be ready to go with it. Our country, because we're so slow to the pitch, we now lead the world, as I think I've said, in terms of COVID infections and COVID deaths. For spending the most money on an illness or on healthcare in general, we're in many ways one of the worst prepared of the developed countries. I want to start going into the healthcare reform thing by talking about scarcity versus abundance. The author Stephen Covey said these are two mindsets for the world. You can view it as scarcity. American healthcare systems based on the scarcity model. Healthcare is too expensive. We can't afford it. We don't want anyone to overuse it because if you use too much, I'm not going to have enough. That's what we have right now with the masks and other things. Other countries tend to use, granted this is all different during a COVID type pandemic, but other countries use an abundance model. We take care of each other because we all benefit from it. And part of our scarcity model, we think healthcare is too expensive. So I think I said this earlier, we make it more difficult to get. We use networks. We didn't need this. In most countries, you need to go to the doctor, you go to the doctor. Which doctor? Anyone you want, whichever one's convenient, whoever's closest to your home. You can go to the doctors, the hospitals, the clinics you choose, not here. That's not to improve your health care. That's because that's the way the healthcare system is funded here. Copays and deductibles, that works to restrict people overusing healthcare. Works very well. So we keep upping copays and upping deductibles. It works better. We restrict coverage. We require prior authorization, where non-medical providers looking at charts tell the doctor, no, you can't give that treatment to this person. And I'll guarantee you, despite their saying this is for the patient's well-being, it's not. These people who are making prior authorization decisions are not examining you as a patient. They never examine you as a patient. Many of them, most of them aren't even medically trained. They're just simply looking at a chart and, oh, in this case, doctor should give them this. And if that doesn't work, then they can try this. If that doesn't work, then they can try what you want to try. We've been doing this for 40 years of reforms, trying to make healthcare more difficult to get. And the result has been we have worse health outcomes than the rest of the world, than developed countries, that is, and we spend twice as much as other countries. When I say twice as much, that's literally true. Twice as much as all but about 8 or 10 other countries who spend more than twice, but a lot less than we spend, more than half, but a lot less than we spend. And again, for the average of all the industrialized countries, we spend more than double the average of what they spend per capita. In the COVID crisis, we see ourselves the wealthiest country on the planet. We now have 5 times the COVID infections, 5 times as many as people from other countries, and over 2.5 times as many deaths. And these numbers actually hold true for countries like India and China, which have populations of 1 billion plus, far bigger than we are, more than the biggest countries and more than the hardest hit countries, Italy and Spain, where they had more deaths per capita. But we're on the way up, and we're way ahead of the second highest country. So we're not doing very well, despite having all this money to spend on healthcare and all the money we do spend on healthcare. I argue we need a new model when we talk about healthcare reform. Police and fire protection is a good model. Nobody has to apply for police and fire coverage each year. Not one of you had open enrollment period for police and fire. You don't have to worry if the local sheriff will accept your police insurance plan because they're out of network. You don't have to worry about paying a $3,000 deductible before the fire department comes. We don't want it that way. A civilized society that takes care of its people with police and fire and schools, elementary education, needs to do the same with health and dental care. That's the model we ought to be using. So I proposed about 10, 12 years ago when I was chairing the health committee that we should have a healthcare system that meets certain goals, pick certain principles that I think any good healthcare system would have, and suggested that this Minnesota health plan was not designed around somebody's bottom line. It was designed to keep people healthy. And one of the criticisms of it has been that, oh, the benefit set you're giving, the benefits you're offering are too good. No other country has them that way. And that's because we're trying to design the best healthcare system in the world. When one of my colleagues said, John, yeah, nobody has that kind of benefit set. You can't do that. I said, is this a problem to have too many benefits that you're going to cover dental and long-term care and mental health and chemical dependency treatment? I think if we're spending twice what anybody else is spending, we ought to have the best system in the world. But, you know, if people want to fight that, we can argue that as we get it through the process. I told you this healthcare system was designed based on some basic principles. I put these principles together in 2003 when Governor Pawlenty was in charge of the state. I actually had a bill that would have his Republican healthcare commissioner design a healthcare system. People said, why would you want a Republican design a healthcare system? I said, I don't care who designs it. As long as it meets these basic principles, I'll sign on. First one's the obvious one, cover everyone with no exceptions. In a pandemic, it's a really wise idea to cover 90% of the people, and 10% of the people have TB. It doesn't matter. Let them wander around our streets. That's terrible public health. We want to cover everyone. We want to cover all their medical needs, including eye care, including dental. You know, our teeth are part of us as much as our fingers and toes are. We ought to cover everything. We want to let patients choose their doctors and hospitals. You should choose who you see, and medical decisions should be made by you and your medical providers, not by insurance companies, not by government, not by your employer, but by medical professionals deciding with you what's appropriate. Reduce costs by cutting administration and by negotiating fair prices, not by denying care. Affordable to all. Our premiums in this would be based on income, not based on how old you are or how sick you are. That way everybody can afford it. Focus on preventive care. I'm going to go through these last ones quickly. Make sure there are enough providers to avoid waiting lines. A couple of countries, Canada for one, has often had waiting line problems. We do too, but some people are very worried if you have a universal system, there are going to be long waiting lines. And ours would, one of the principles I think you need is to say there'd be enough providers to avoid waiting lines. We want to maintain our leadership in medical care. We're one of the best states in the country, one of the best countries in the world in terms of the care that's available to those who get it. We want to pay providers in a fair and timely manner. For most of us, if we're not medical providers, this may not matter to you. Yes, it does. You want to have providers paid fairly. You want a healthcare system that works. Finally, we want a simple and understandable funding and payment system. You get those things in the mail saying, this is not a bill. Well, why'd you send it to me? They're confusing. People can't figure it out. One business actually goes in and tells employers for a couple $100 per employee, we'll check all their medical bills for the year and we'll catch mistakes in them and we'll make sure you get the money back. And they make a good business doing this. They don't provide any care. All they do is help people with the convoluted system we have. In any case, those 10 principles, we designed the Minnesota Health Plan around them and legally would be binding them to them. Article 1, Section 2 of the bill says that the health plan is legally required to stick to these principles. How does it work? This is going to be a real brief summary of how our proposed Minnesota Health Plan would work. Covers everyone with no exceptions. You don't have to qualify, and you don't have to worry about deductibles and copays. You're not going to be turned away because you can't afford it. Everybody's covered. Covers all your medical needs. I mentioned that earlier. You choose the providers, medical decisions. I mentioned this earlier. It's affordable to all, focus on prevention. All the principles are there. And this does. Remember, I talked about 4 different flaws in our healthcare system that the principles that the pandemic exposed. The Minnesota Health Plan would address all of them. Certainly eliminates the cost barriers to care. Nobody's going to say, I can't afford a test, I can't afford treatment, I can't afford to go to the doctor even though I had a scan that shows I have some potential cancer. Second, it establishes a logical system with planning and coordination. It stops the bidding war between states and so on. It would help the hospitals. Again, you plan because it's required to make sure enough providers in various communities, the system would be required to make sure there are logical healthcare facilities throughout greater Minnesota, rural communities. You might not have a level 3 trauma unit in a tiny town in Roseau or someplace in far corners of the states, but you're going to have within reach emergency rooms that can handle this. Planning and coordination is pretty important, and nobody's in charge of it now. We would have that through Minnesota Health Plan. It's driven by public health, not profit. No more of the bidding wars and price gouging. And when people talk about the difficulty of rural hospitals, they say, rural hospitals, they can't make it now. They're going to be killed under Medicare for All type of proposal. They're going to be clobbered because they're going to reimburse you for less. No, they're actually dying out now. They're being shut down now for profit decisions. The Minnesota Health Plan, as I said, would be legally bound to make sure there are enough needs out, enough facilities and providers to meet the needs. And if they have to, in order to get the right kind of doctors and providers in certain communities, whether because of low income or because they're small rural communities, they have to pay more. You may have to pay more to get doctors in rural communities. Minnesota Health Plan would be in charge of making that happen. And because payments are based on ability to pay, premiums are based on ability to pay, it's not going to cost people there more. If they're lower income, it's going to cost them less. The system as a whole makes sure it works. That's what a logical, quote, insurance system is supposed to be about, so on. Finally, it slashes the bureaucratic paperwork. You're not going to have those prior authorization problems. You're not going to have hundreds and hundreds of dollars worth of billing costs and collection agency costs when somebody has a long hospital stay. You eliminate all those costs. Okay, so I've been talking here now, check the time. Sounds like a great health plan, you might say. I hope you think so. It would cover you for everything you need, and you get to choose the doctors, what's not to like. Well, how are we going to afford it? Can't afford what we're doing now. We can afford to cover everyone for all their medical needs. Well, bottom line here on the screen, it may sound counterintuitive, but the evidence and the research shows it's actually less expensive to cover everyone for all their medical needs through a single payer system. When I say cover everyone, right now, in Minnesota, we insure about 95% of the public almost. That was before the COVID crisis. Now there have been about 10 million people who lost their insurance at the time they most need it during a pandemic. But it'll be many more than that a month later as people have been unemployed for a while. But covering 95% or 80% or whatever we cover in various states now actually is cheaper to cover everyone for all their medical needs through a logical single payer. And I say that both from economic analysis of various plans here, including one study done in Minnesota, studies done in numerous states, and the empirical evidence from around the world. It's actually cheaper. Okay, so what's single payer? I mentioned single payer. Most people have heard of it. Most people know they love it or they hate it. But what is it? Well, it's doctors and hospitals paid by one payer, not multiple ones. You're not dealing with insurance companies and government and businesses and individuals, everybody pumping stuff in. Would all be paid through a single payer. It would be by the Minnesota Health Fund, which would be a governmental division in effect of the Minnesota Health Plan. They would be taking payments from businesses and from individuals and from government. You wouldn't have insurance systems. We'd all be paying premiums. Premiums would replace your copays, your deductibles, your uncompensated care, your everything. Everything you pay now, you'd be replacing with premiums based on ability to pay. And if it is cheaper, as I would argue it is, and evidence shows it is, you'd be paying less in your premiums than you're paying in your premiums, copays, deductibles, and stuff now. It's not very descriptive. When I say that, I think you could use the argument as I have before that if you buy a new car and I ask you, what kind of car did you buy? You tell me, dealer financed. That doesn't tell me much. I say, well, what kind of car did you buy? Dealer finance. You insist. That's what we're going to tell you. Well, single payer doesn't tell you everything about it either. The only thing it tells you is that by being financed by a single entity, it's a single system. Everybody's in. And I would argue it's probably the only way to get universal health care in American politics. Yes, some other countries have other ways, but I don't think we could do it here. Why? Because, well, let me go back a second. Well, I'll get to that later. Why I think it's the only way you could get it covered. When people say it's cheaper, when I say it's cheaper, and lots of studies say it's cheaper, but wouldn't it require a huge increase in taxes? We use premiums for what we're paying, not taxes, but you could call them whatever you want. Medicare for all. Does it cost $32 trillion more? The Mercatus Center, which is at George Mason University, funded by the Koch brothers, that tells you their politics, they said a Medicare for all, like Senator Sanders has proposed, would cost $32 trillion with a trillion with a T over the next 10 years. Or is it $2 trillion less, which you could also read their study to suggest if you read it a different way. There was a center at University of Massachusetts at Amherst that said it would cost about 6 or 8 trillion less over 10 years. But what's the number? 32 trillion, 2 trillion less? That's a big gap. The 32 trillion refers to the amount of additional government spending that you would have under their estimates. And again, I'm not buying their estimates. I do not trust the Koch brothers funded research. But if you do trust it, they're saying government would spend $32 trillion more. But when you look at it, they're also suggesting the total might cost $2 trillion less because the private sector might be paying about $34 trillion less. So I'm going to make the case that I think it is actually cheaper. Sorry about that. How can it be less expensive other than just telling you that the studies show it is? I'll give you two main arguments. There are dozens that I could come up with, but the main two I would say is logical pricing and cutting bureaucracy. Let's take a look at each of these. Logical pricing, Minnesota Health Plan would negotiate fair prices. We don't do that now. You don't think so? The insurance companies, aren't they fighting to negotiate low prices? Not necessarily. Current price disparities, and these are covered by health plans. Price disparities, there was a study out of Yale about 3-4 years ago. The basic price for a knee replacement ranged from $3,400 to $55,000. You do the math, that's about a 16-to-1 price disparity. And that's not the way our economy generally works. You want to buy a Toyota Prius or a Ford pickup, you pick the model, you pick the options you want, you go shopping at 2 different dealers. I will guarantee you, if you shop carefully, you can save some money. You might spend $500 less. You might save $1,000 less if you're a good shopper. You might be spending 5-10% less if you're really a good shopper. You're not going to spend 1,600% less. It doesn't work that way because the rest of the economy has a market-driven economy. They're actually some price competitive, or there's a good negotiation system in place so people have a choice. But we don't have good price negotiations, and hospitals can basically charge what they want. If you go in for most types of things, if you try and knee replacements, one of the things you might be able to negotiate because you don't need one today. You usually can plan about that for a couple months from now or 6 months from now, you can plan for it. But most things, you get COVID, you're not going to be negotiating with a hospital. You get a heart attack, anything else like that. Frankly, most things you see medical care for, there's no way you could negotiate. But anyhow, 16-1 price disparity. Or look at pharmaceutical pricing. I don't have to go into that, but we have paying sometimes as much as 30 times. I know a couple of cases like 100 times more for a medication than you'd pay in other countries. The same medication, same manufacturers, same everything, but other countries negotiate prices and we don't. Matter of fact, the federal government has banned Medicare for negotiating prices for seniors. So when they passed the Medicare Part D package about 15 years ago, 18 years ago, when they passed that, the Congress actually prohibited the federal government from negotiating prices. The genius who wrote that bill, a congressman named Buddy Townsend from Louisiana, he was the chair of the committee. He wrote the legislation. The week it passed, he resigned from Congress, took $1 million a year job lobbying for pharma. You get a sense of how things work. Cutting bureaucracy. We eliminate insurance and billing bureaucracy. Yeah, we all complain about bureaucracy. Oh, we all want to cut it, but yeah, you might save 1-2%. No, maybe. I'll use for an illustration of that. What if we funded our schools like hospitals? Sorry for the cheap clip art, but it was my graphics trying to do something. If we funded schools like hospitals, education would change. They would charge each student for time and resources spent, and there's huge variation there. We would have school insurance. And education is very expensive. You couldn't afford to pay the bills outright. You'd have in school plans. Think of the billing and insurance bureaucracy. And, you know, employers would say it's so expensive to buy school insurance, they'd start offering benefits for their employees. That's what we do for healthcare. You know, their employees, their kids need to go to school. We'll cover you at this plan. Maybe you can buy a gold level plan instead of a silver or tinfoil plan, whatever they call them. Think of the bureaucracy. Instead of, you know, in Minnesota, instead of Medica, we could have Educa. For health partners, we could have education partners. They might open a branch. Blue Cross could have their own Blue Plus for education. UCare could have ULearn. All these good plans. Think of the bureaucracy and all the people they hire and everybody else. And think of the insurance. Think of the amount of time parents would spend filling out the things and paying the co-pays and deductibles and everything else. Think about all those businesses doing it. Think about the schools having billing offices and collections offices because people don't always pay their bills. Would it improve education? Of course not. Shift resources from teaching to billing. That's for teachers and administrators. If you switch schools, you may have to switch schools. If you're out of network, you switch jobs, you get a new plan. Oops, that school's out of it. And some teachers in your school aren't going to be covered. So you're either going to be cut with surprise bills or your kids aren't going to take those classes. You don't have coverage, you don't get an education. Maybe the federal government or the states would step in and give charity education to people. Would it save money? Of course not. Think of the huge waste of time here. So why would anybody do this? Would anybody think this is a good idea? And I'm not arguing we should do that. But would anybody say that's a logical way to do it? Why do we give universal education? Because we want every child to get education, everyone with no exceptions. Undocumented kids, they get an education. Immigrants of all types get an education. Kids with disabilities get an education. Rich kids get an education. Poor kids get an education. We want 100% of the kids to get an education because it's good for society. We want 100% of the people to get health care because it's good for society. Not just for them, it's good for us, which we see in a pandemic. Okay, the politics of this. I'm going to quickly check the time. I'm going to go a few more minutes and then I'll open it up for discussion. The politics of this. Aren't there many ways you could deliver universal health care? I mentioned this earlier, not in the US political system. Other countries do deliver it through Germany and Switzerland, for example, have multi-payer systems. They have health insurance plans. But there's a difference there. There's a huge difference there. In Germany and Switzerland, if I'm an insurance company there, anybody who comes to me saying they want coverage, I have to give it to them. The prices they pay, it's determined. The prices we pay for what we cover is determined. What we cover is determined by the system. In other words, everybody's getting paid the same amount regardless of the patient, regardless of which doctor, clinic, or hospital. You can go to any doctor, clinic, or hospital. In other words, the government tells the insurance companies what they have to do. In our country, the insurance companies tell the government what they're willing to do and what the government's going to do. And so we have a system with multiple gaps. You can look at it if you buy insurance through the insurance exchanges, which are only for 5% of the public. The rest of the public gets it through either public programs for about 30% between Medicaid, Medicare, the VA, TRICARE for federal employees, public programs, and employer-based insurance, about 60%. So only about 5% of Minnesotans get coverage through the exchange, and yet even there, different members of your family may be covered through different ways. Some may get a bronze plan, some may get a gold plan. The bronze plans really are, I sort of said this earlier, but they're really more like tinfoil plans. They're cruddy coverage. 40% of your costs you're going to be paying out of pocket in copays and deductibles. In any case, a system like this leads to huge gaps where people fall through the cracks. Even if you are covered, you lose your job. Oh, a pandemic, you lose your job? Well, okay, well, I'll do without coverage for a while in the middle of a pandemic. That's why we, even with our system, any way you design it, in our system where powerful interest groups manipulate the political system, you're going to have people falling through the cracks. For people who think you could design a non-single payer universal healthcare system in the US, I say, hey, show me. If you think there's another way to do it, show me somebody who has another proposal and tell me how it's going to really get you to universal healthcare. This is something that Harry Truman started fighting 75, 85 years ago, started pushing for. It started with Frances Perkins, Franklin Roosevelt's Secretary of Labor. It was part of her plan for the New Deal that never got enacted. This is almost 100 years, and people keep saying, I've been around the legislature for a long time, and Minnesota Care was going to cover everyone. It was going to cover everybody within a decade. It hasn't. It won't. It can't. Affordable Care Act. Oh, it was universal health care. It was promised that way, and we know it wasn't. We knew at the time it wasn't, but it covered more people, which was good. But still, if you want universal health care, you're never going to get there other than this. Pandemic has changed when we're still talking about the politics of universal health care. It's totally changed. Republicans and the Democrats, many Democrats who have opposed Medicare for All now favor it, but just for this one disease. It's amazing how the COVID crisis has changed this. I mean, Republicans now, even Trump and Pence are talking about how they want a paid sick leave. They've hated that stuff. That's socialism in their mind, paid sick leave. They oppose it everywhere and they can. And now for this, Mike Pence said about a month and a half ago, he said, if you are sick, stay home from work. Stay home if you're sick. We don't want you to be worrying about whether you're going to lose pay or not. We'll cover you. And they meant it. Well, not very much, but they did support passage of a paid sick leave for some of those who don't have it, just for this one crisis, though. So it has changed it. People have had to change their hearts on it. If even Republicans do. But I'll say one more thing, and that is that's the politicians saying these new things, but they haven't really changed their mind. They've recognized in the crisis, everyone's at risk. If we have some people out there who aren't getting treated. So even from the beginning, Republicans were joining virtually every Democrat saying, oh, at least the testing will be free. They're not there with the treatment yet. They've been considering. A lot of Republicans have saying, yeah, we got to reimburse the hospitals for their costs for treating people who aren't insured. But that's not something, there are a lot of opposition to that. We couldn't get that in law in Minnesota in the last couple of weeks because of Republican opposition. Politics have changed. Not all the elected officials have changed, but the public is seeing change is more urgent. So I'd argue the politics have changed. Then real quickly, before I said I'd stop by 8, so I got a couple of minutes yet. I'm going to talk about a few frequently asked questions. When Trump was elected in 2016, during the 2017 session, we were going to introduce our Minnesota health plan again, and we started rounding up more co-authors. We weren't going to do anything. Republicans were in charge. We wouldn't get a hearing, but we just said we'd get some co-authors. We ended up with about 60 co-authors again. And so I thought, well, somebody said, why don't you have a news conference to announce you're reintroducing the bill? And I thought, okay. And somebody said, the first question they're going to ask you is, isn't this government health care? And didn't the voters reject that when they picked Donald Trump? I said, this is not government health care. I don't want government or employers or insurance companies interfering with our health care. Our current system, government's interfering every step of the way, as are employers and insurance companies. This is basically a patient-provider-based system. Who makes the final decisions on the care you get? You do. You pick the providers. You and your providers discuss together what kind of treatment you want, and you're not being forced into something else because some insurance company person says, no, we're not going to give you prior authorization to get you that treatment. We want you to do this instead. So it's not government health care. That's my argument. They can call it whatever they want, but I argue it's not. What about loss of insurance industry jobs? This is a serious matter, and I'd argue we have a moral and economic obligation to address. The Minnesota Health Plan and the Medicare for All plans in Washington cover dislocated worker benefits and retraining. And to put this into perspective, because it's a huge hit, nothing like what we're in now, which we have to get out of, but it's nothing like that. But in Minnesota, they said it could be as many as 40,000 people losing their jobs. Just for putting that in perspective, however, there are about 150-some thousand jobs that change every month. 155,000 people were losing their jobs every month, and about 100 in times of higher employment, 156,000 were gaining jobs every month. Some of those are people losing their jobs because they're retiring or taking a new job, some because they were laid off. But bottom line is the number of total jobs we'd have displaced by this would be about 1/4 of 1 month's typical job changes. And we'd have a couple of years to plan for this and to provide those benefits. And I think we do have a moral obligation to deal with that. I don't think we should dismiss that as a minor issue. It's a very significant one. But we'd be better off, seriously, we'd be better off if we took the people working in insurance and billing related things and paid them to sit at their desks doing nothing than we have for them filling out things so doctors and nurses have to fill out things to send into them. So you have to sit at home and your employer has to calculate all this. You have the paperwork shuffle you have. So it would be a huge savings to people in doing this, even if we just pay them to sit at their desk, but that's not a serious proposal. The other thing I'll say about this is that those 40,000 people, if they were dislocated temporarily while we help them, not all of them need retraining. A lot of nurses are doing billing work and so on. The former CEO of United Health Group, the biggest health insurer in the country, Bill McGuire, he's the owner of the soccer team in Minnesota. He's a medical doctor. He would not have needed retraining. I don't think we could match his $105 million a year salary, but he wouldn't have needed retraining. But they don't need retraining in many cases. They do in many others. We have to take it seriously. But the one guarantee they have is the day they lose their job, they do not lose their health care. And that's a life and death difference for people. Maybe one more FAQ. What about a public option? Lots of Democrats say, we want Medicare for all who want it. And I'll say, yeah, it's better than what we're doing now, but it doesn't change much. It doesn't save money. It might be a little bit better for those, the traditional Medicare might be a little bit better for those who want it. But again, the traditional Medicare doesn't cover long-term care. It doesn't cover dental. It doesn't cover a whole bunch of things. And so it would be a better thing, but the way the system is set up, insurers would cherry pick and they'd push people who have diabetes and more expensive conditions, they'd push them into the quote public option and making it unsustainable. So it's not going to change much. I think basically, if you want a system that saves money, if you want the efficiency, if you want to do away with all the billing hassle, if you want to do away with the co-pays and deductibles, a public option doesn't change any of that. And what about one more? Long waiting lines, that's due to a shortage of providers. It does not correlate to single payer. Canada has a single payer system, and they do have waiting lines, and they have a nonprofit that's advocating for change of that, and the government's actually been putting more in to change that. And even the advocacy group says, we don't have to have this. There are lots of single payer countries that don't have waiting lines. It's nothing inherent to single payer, is that Canada doesn't put enough resources into it. And they're spending, again, less than half what we spend on healthcare, less than half. So they could probably spend half what we spend and do away with the waiting lines. But in Minnesota Health Plan, we have a legal requirement that they have to have sufficient providers to meet the needs. So this would not be a problem here. And as I said, now there are many people now who can't even get into the waiting lines because they don't have coverage. So anyway, hope that helps with that. Learn more, you can download a free copy of my book in Kindle or whatever types of whatever kind of ebooks they have, or just PDF if you don't have an ebook reader. And with that, thank you, and I will stop sharing and welcome questions, etc.
Thank you, Senator Marty. It was very in-depth. Certainly, the proposal you are putting forward would make a huge change to the systems we currently have. So I think that's what some of the questions I'm seeing are about. For instance, you talked about it covering all our health needs. So how would that work as we age, as we go into nursing homes, or if we are in a serious accident and need to go into a rehab center?
Right.
How does it work there?
It works the same as it works for getting a flu vaccine right now. A lot of places you don't pay anything for flu vaccinations because it's considered part of your health care and preventive care even, so they don't charge anything for it. So it would work that way. There's the one difference is for long-term care. For long-term care, we would be charging for people who are not, the only place we're doing means testing, we'd be testing how much income people have, whether they can afford to or not, would be for the housing portion of long-term care. If you go to assisted living facility, which a lot of people need, it's better than nursing home if you don't need a nursing home. We cover in-home care too, which would help a lot of people with that. But if you did go to assisted living facility, you could pick a really nice place and your needs might be really minor, or the medical needs of it we'd be covering through the health plan, the housing needs you'd be covering. Again, if you were low income, Medicaid eligible like now, you would be covered by the health plan. But for other things, we would be covering it all, which is again why people say, the sky's the limit, you're gonna have people pay for all this stuff? How are we gonna afford it?
Yeah, thank you. So like another place that this would impact in another part of the complicated system is currently there are things beyond health insurance that cover some of our health needs, like auto insurance will cover people's car accidents, or workers' comp insurance covers the health care of workers, or the injuries of workers. How about those? Would those go away?
Those are exactly the two that are most common. The two areas where almost all of us, or anybody who's working and has a car, all of us are covered by those two insurance things. It would save some money for those two plans. For auto insurance, it might save 30–40%, I think the numbers showed. For workers' comp, it's saving almost half the cost, because half of workers' comp costs are going to lost wages because you can't work then and so on, and for pain and suffering, things like that. You lose an arm, the workers' comp system doesn't compensate you very generously, but it does compensate you for loss of an arm or a loss of sight or whatever. So some of those payments you'd need workers' comp for. And same thing with auto insurance. A lot of auto insurance is to cover damage to vehicles and other things like that. So you'd need auto insurance, you'd need it, but the cost of those premiums would go down because the Minnesota Health Plan would cover that. If you're in an accident with somebody in another state and they have auto insurance that covers this, our plan would try and capture that money for paying for your costs. But basically our premiums in Minnesota would go down for both of those because the health plan would cover it. And one of the biggest arguments for doing that is I've had back surgery. I have lower back surgery twice in my life. I don't want it again, but I've had it twice. First thing you have, if you have any back pain, you go to see a doctor. While you're waiting in the waiting room, they give you a clipboard and say a questionnaire. You don't have that if you have an eye problem or some other kind of problem with your health, breathing problem. They don't ask you that. But if you have a back injury, back problem, they ask you, were you in an auto accident? Did the injury occur at work? Why? Because they want to fight in court to make somebody else pay the bills. And of course, the employer, the payer of the workers' comp or the auto insurance company, they want to fight it too. So they're going to fight it. So the two insurance companies are fighting with each other in court. And in the end, we're spending a lot of money fighting in court for something that doesn't make any sense.
Right. Thank you. Here's a question that's a little different focus. You touched earlier on the pharmaceutical industry and how they are price gouging in our system, and how they were not allowed to, I mean, the government is now allowed to sort of cap their prices.
Right.
And then with COVID-19 happening, we're all starting to wonder what's going to happen if, if something is developed, a vaccine, that's the word I'm looking for, is developed to fight the virus. Is anything being done to make sure that vaccine is going to be accessible to everybody?
I will guess with a crisis like this, it will be accessible to everyone, and our government will pay through the teeth for it, because the legislation that Congress passed related to this, the pharmaceutical lobby, which I think is one of the biggest, if not the biggest lobby. They have several lobbyists per member of Congress. I mean, it's just bizarre. It's a hugely expensive lobbying effort. They're very successful, and they took out the provisions on price gouging, which is very troubling, because, you know, a lot of the dollars going into the research are funded by governments here and around the world, and these researchers around the world are out sharing all their information. And yes, it makes sense to work with the pharmaceutical lobby, pharmaceutical companies, excuse me. It pays to work with them in developing the vaccine, but since a lot of the research dollars are coming from the public, it should be priced at a rational way. Jonas Salk, who developed the polio vaccine, he gave the vaccine to the public. That's happened many times over the years. Why? Well, he was paid as a researcher. He was paid as a doctor, as a scientist. He was getting paid to do his work, and this comes out of it. Well, yeah, I don't need to become a billionaire just because I developed this. I was doing it. I'm a doctor. I'm a medical researcher because I want to save lives. And I don't care if we let them make a good profit off it. I think they should make a good profit off things. But this price gouging thing, it's a bizarre way to run a system.
Yes.
Go ahead.
Somebody shared their screen, I think.
Yep. So, okay. Anyway, I can still see you. Go ahead with questions.
Yeah, I'll go ahead with another question. You talked a little bit about how intentional barriers have been added to the healthcare system over time. So these barriers are designed to limit how people access healthcare so that we don't have more expensive healthcare.
Right.
But in reality, what it ends up doing is prevents people from getting the care they need. So maybe even enhances the amount of cost to the healthcare system. Can you talk to that about that a little more?
Yeah, you faded it a little bit at the end there, but I would argue, yes, it definitely is making it hard for, it's definitely making it harder for people to access healthcare. Can people hear okay?
Yes.
Okay.
Yes.
Yes, it's making it harder for people to access healthcare. And that's intentional because we don't want anyone to overuse it. I hear my colleagues say all the time, our biggest problem is overuse of healthcare. Well, you know, we do have things like over-testing because one provider gives you a test, and because they're not sharing the test with everybody because they're all different networks and so on, and therefore we're not sharing the test results, so people get the same tests over and over. Some doctors practice defensive medicine, and just in case so I don't get sued or anything. And there's some of that going on, but for the most part, you know, that's a tiny portion, but we keep acting as if, first of all, if you get a test, if you have a test for breast cancer and it turns up negative, does that mean, well, I didn't need the test, I don't have breast cancer? It's part of it. It's a test to find out what you need and what you don't need. And that makes sense. And so I would argue that we really have a problem of underuse of healthcare more than overuse of healthcare, and there are ways to restrict it. I keep telling people, and one of the things people sort of disagree with, um, I've talked to some doctors who even disagree with this, but that is that when I say who should ration healthcare, supposing we feel a need to ration healthcare so we're not all going hog wild. I heard some Republicans once say, think of healthcare like food. What if food's a necessity? So what if food was free to everybody too? Oh, people would go to the grocery stores. What would they get at the grocery stores? They would buy dog food instead of dog food. They buy steak for their dogs. They'd go hog wild with the best food for everything. Well, food's a little different than healthcare. I know a lot of people, if they had more money to spend on food, they'd buy fancier foods. They go out to eat more, et cetera, et cetera. I don't know anybody who thinks, hey, I haven't had a colonoscopy for 3 months. They were so much fun. I think I'll go get me another one. It's free. People don't do that. They don't go wanting more knee replacement. Oh, a shiny new knee. That's painful. They don't want that just because they can get it for free. Nobody does that. So I would make the case. I'd make the case that making doctors and patients be the ones who ration care makes sense. Gunderson Health Clinic, which is La Crosse, Wisconsin area, so they cross the border from Winona. It's the major healthcare system like Mayo in southwestern Wisconsin. About 15 years ago, Gunderson put in a new plan for seniors. They were trying to make sure everybody has living wills or advanced directives and so on. So nurses and people would talk about the kind of healthcare they did. And they made national news coverage about how effective they were at saving money. They said this wasn't meant to save money. This was meant to make sure people get the health care they want. And what they found out was people who are planning their end of life stuff, they don't want the latest of everything when they're dying. They don't want to be put through more surgeries and more torture when they know they're dying and the surgeries won't do much good for it and it won't extend their life long. So when you talk people through things, when doctors and nurses talk patients through their options, seldom does it become the most expensive thing. Sometimes it does, and sometimes it needs to. But that's why I say that this whole thing about overuse of healthcare being the problem, we're the only country that does this crazy system of trying to deny people healthcare. And we're the one system that's off the charts in cost.
Great. Thank you. That's a really interesting way to look at it. What about elective surgeries? As you were talking, it just occurred to me that, there's going to be, I can see some gray areas where somebody says this is necessary and somebody else says, no, that's a cosmetic change.
Right.
How is that going to be handled? Okay,
we actually do go into in the bill. By the way, you can access the bill online. It's if you go to the Minnesota Legislature webpage, it's Senate File 1125. The bill is only about 30 pages long. Unlike the Affordable Care Act, which is 2,000 pages, this one's actually quite readable because it's 27 pages, and I think every one of you could figure out what it's saying. And you look at the list of benefits and what's not covered, and the list of what's not covered is pretty minimal. The one I can recall is elective, purely cosmetic surgery. We do cover some cosmetic surgery if you have cleft lip, if you have port wine stains, if you have breast cancer and you want breast replacement. All those things are covered, but it's purely cosmetic stuff. I don't like the shape of my nose. I'd like to change it. That might not be covered because that is something people, that's not a medical need. We're trying to deal with medical needs here. But other than that, I think we were going to have we actually were trying to find things we could say, hey, no, we're not covering frivolous things. So I was actually proposing we include in the package, private hospital rooms. Talk to a number of doctors. That's a terrible idea. The push is to have more private rooms in hospitals because with infectious diseases and so on.
So you just muted John.
Oh, I'm sorry. I was trying to get Sherry's screen off there. Hang on.
Yes. Yep.
He should be back.
Am I back? Okay,
You're back. I'm so sorry.
That's okay, no problem. but we were going to try and say it was going to cost extra to have a private room in the hospital. So the doctor said, no, for infection and other reasons, that's a medical necessity in many cases. And let's not set those aside. Then you're deciding this probably isn't a medical need, so we're going to charge you extra for it. And bottom line is we don't want two tiers of healthcare coverage. Some people, I mean, even in England, which is a good healthcare system, even in England, what they have is a system where some people get their private coverage, which is more expensive. And they buy their own coverage instead of the public one. I don't like that idea, because if we want to ensure the best quality healthcare system, how do you do it? You want to make sure that the governor and legislators and CEOs and doctors and everybody, they get the same healthcare system as you get, because they're going to make sure they get a good healthcare system for themselves and their families, and you want the same thing they want. So I think the main thing we have to do there is make sure we have the same coverage for everyone. And so we cover comprehensive benefits. Again, the only one I remember that we have in the bill right now is purely elective, not medically related cosmetic surgery.
Great, thank you. So what would you say to people who object to being forced to pay for coverage?
Sure.
How would we ensure that premiums are paid?
Yeah, well, first of all, the premiums would be paid. Here, this is one where people say, oh, it's just a semantic choice you're using. Well, the Republicans, one person told me, Republicans are going to call them taxes. I said, hey, they can call them anything they want to call them. If we collect them, I acknowledge in the bill that they'd be collected by the Department of Revenue, and they'd be similar to our income taxes. The less money you earn, the lower percentage of your income you pay into it, because we want to make sure everybody can afford it and so on. Everybody pays something. If you make more, you're going to pay more. How you're going to make sure they pay it, it's a legal obligation you have, just like your taxes. That's why they could call them taxes if they want to, but they'd have to pay them. And bottom line is, should they have to? Yeah, even if you don't have kids, you have to pay for education, because that's part of our cost of society. Even if you don't drive a car, you're paying for lots of things in the roads and so on through our taxes. A lot of them are user fees in transportation, but we all pay for all those things we don't use ourselves. We pay for fire coverage even if we've never called the fire department, because the society needs to take care of itself that way. So yes, we'd be requiring everyone to pay, and people may object to that. But again, I think you'd have less objection to have to the Affordable Care Act, because part of the objection here was, oh, I'm paying more and I can't afford to pay for dental care because it's not covered by my insurance. And you're going to give those people coverage? You're going to give those people coverage? No, if everybody, that's why I think you need a comprehensive benefit set. Low-income people need dental care too. And if you're going to cover it, you better be covering it for everyone, or people are going to be saying, why should I pay for somebody else when I don't even get it?
Great, thank you. So how close is Minnesota to getting this system today? And can this work well if only one state does it?
Good questions. There are two separate ones. If I forget the other one, I'll start with the other states and so on. It would work better to do something at the national level. I would argue some of the people at Physicians for National Health Plan, PNHP, they argue, state efforts aren't worth the work. It wouldn't work as well and everything else. Hey, I acknowledge we have more burdens to go through as a state, because one of the things we'd have to do is, you know, if healthcare is free here, won't everybody move here to get healthcare? And in order to prevent that, one of the waivers we'd be asking from the federal government would be the ability to charge other states. If they're not providing universal healthcare, if their people move here for healthcare coverage, we should be able to bill those states for it. So it's a long effort. We'd be asking for extra need. You don't need to do that at the federal level. If you get sick, my son was studying in Italy for 6 months a few years ago, and he needed an MRI and everything. He went in, and after he got all this stuff, he was, well, okay, how much do I pay? And he was there long enough. He was supposed to be covered by their system, but he couldn't get them to, Italy's a bureaucratic country, and he couldn't get them to take the stuff. And at the end, the doctor said, no, you don't owe anything. I've talked to so many people got sick in Ireland, they leave the hospital and, what do you mean I don't owe anything? They knew it would be less than it would pay here, but they didn't know they'd get by free. Other countries provide care to the visitors in their country. We don't. And one state would have trouble doing that. So it would be preferable to do it at the national level. But, you know, in Canada, It happened in Saskatchewan in 1962. Within, I think, 8 years, the federal government, the entire country had it. You do the right thing someplace, other people like a good idea. And so I'd prefer to have it happen at the national level, but I'm going to fight at the state and national level any place we can. On the second question, how close are we to getting it? Well, I wrote a commentary for a Catholic social justice journal a couple years ago because I saw an article on there where he was saying Democrats ought to slow down on single payer because he said they're pushing too fast. And I wrote a response saying, too fast? This has been something since the Truman administration. And you think we're moving too fast? I'm tired of waiting. People are dying because we don't cover up. And I'd say it's long overdue. I actually think there's a chance we could do it in the next 4 or 5 years. I can't guarantee that. What I can guarantee is politics is a very uncertain thing, and people who know what's going to happen in the future are wrong. I did, in 2008, I had introduced on totally unrelated issue on marriage equality. I had introduced the marriage equality bill, first bill to get a hearing in 2009. I said at the time I thought it could pass in 5 years, not as a prediction. I'm not a predictor of things like that. I was trying to say that, if you believe you can do something, you can make it happen. If you think it's never going to happen, it's never going to happen. You got to have confidence in your convictions. You got to fight for it. And 5 years later, my church came up to me after it passed in 2013, not my bill, but a similar bill. And he said, John, I want to apologize. I said, what for? He said, back in 2008, this is the kind of guy who pays careful attention. Back in 2008, you said you thought that we could get this thing in 5 years. So I told my friends you were nuts. He knew I was wrong. And he said, I knew it was never going to happen in my lifetime. And it happened. And he couldn't predict that, and I didn't predict it. I guess I came as close to predicting it, but I was just saying it's a possibility you could do this. And for those who could have guessed that, and I don't think anybody did, but if anybody who did predict that, how many people thought in 2015 we'd have Donald Trump as our next president?
Yeah.
I mean, nobody did. Not reasonable people. Some might have, his campaign manager probably said so, but he didn't believe it. Nobody believed it. I don't think Donald Trump actually believed it. You can't predict those things. And 2 months ago, who would have thought that we'd be talking about issues like this over, instead of me being there in person, which I wish I could be, but instead of doing it that way, talking by Zoom, nobody can predict these things. So those who make the predictions are the ones who are going to be wrong. And I think something like this is going to happen like that. And I think something like the COVID situation could give this kind of spur that makes that happen. Previous generations didn't wait. They fought, even though they knew they couldn't happen. I've often argued if the progressive movement of today were in charge during the abolition campaign in the 1850s, because we're so lacking confidence that we can ever change anything substantial, we'd probably still have slavery, but we'd have limited the slaves to working 40-hour work weeks. We'd be so proud of the progress we made that we'd forget we had this ugly thing called slavery. Or women's suffrage. They had no chance. Who made the decisions? Men did. Who elected the men who made the decisions? Men did. No chance. But they fought for it, and it happened. And so I got to say that by believing you can do it and fighting for it and having breaks, this is not a lucky break, the COVID thing. It's a horrific situation, but it does change the situation, does change the dynamics. And if you look at the polls have always said, in recent years, have always said Medicare for all type of concept, universal health care type of concept, has roughly mid to upper 50% support, 55, 58% support. Goes up and down and depends on how you frame the question. But basically, it's popular support for it, despite the fact that there's billions invested by pharma and insurance companies to fight it. So I think we have a chance, and when, I'd love to have it happen in the next 4 or 5 years.
And so as you were talking there, you were talking kind of in general, both about either happening at the Minnesota level or at the national level. Is that correct?
Yes, and I think the national level is likely to be slower, but again, things change very quickly sometimes when you least expect it. We have I think I mentioned 60, maybe close to 70 co-authors in the legislature. Unfortunately, all of them Democrats. We're not in charge in the Senate, but if we take control next year, I'd love to start pushing it forward. And during the Plenty administration, the bill was first introduced in 2007 or 8. And I got the bill through about 3 or 4 Senate committees. We knew it wasn't going to go anywhere. The House could have passed it. I mean, I don't think they could have, but if they did pass it, Plenty would have vetoed it anyway. I think we've got a fighting chance, and I'm doing everything I can to make it happen.
We need to get our House and our Senate flipped over
Yes.
so that it can get passed through. Then we'd be
Yes.
good.
We have a
Yeah.
number of, one of the, probably our most probable Senate pickup seat in western suburbs. Woman who's now running for it is a DFLer, who I expect to be a new colleague. She came to one of my talks on this back last September or so, the week she was deciding to run. And she's proudly saying she supports this. And I told her the worst thing you can do is say you support this and then back away from it. And if I can give one illustration here, I'll bring up Al Franken, because when he was in the Senate a few years ago, he signed on to Bernie Sanders' Medicare for All bill. I wanted to talk with him because he didn't do it with a lot of enthusiasm. He showed up at a news conference and he said, well, I support this. My good friend Paul Wellstone, he authored this bill. He authored a bill like this. And so I think it's something we ought to consider. Keep thinking, that's real enthusiasm.
Yeah.
And I wanted to talk with him, and he left office a couple months later before I had a chance to. But I was going to ask him, why are you so timid about this? I picture, this is a hypothetical conversation, so don't hold it to him. Hypothetical, he'd probably say, John, you know what they'd call me if I supported that? They'd call me a socialist.
Yeah.
I would have responded, Al, what did they call you when you supported the Affordable Care Act? A socialist.
Yeah.
Okay, well, they'd fight harder against me if I support this. Well, really? How much do they spend against you? I don't know what they did spend. It was probably 10, 15 million, whatever they could raise. If they could have raised 20 million, they would have spent every penny of it against it. They're not going to fight any harder against them. They're already fighting as hard as they can. So they're not going to call you different names. They're not going to fight harder against you because of it. I think what would have happened if he had stayed in the Senate and continued talking about this, his first speeches would probably have been of the nature of, halfway through a speech on healthcare, he'd say, and, I signed on to Bernie's Medicare for All bill, and I think it's something we ought to consider. I think he would have gotten something I'm not surprised by, but he and others might have been. I think he would have gotten applause from whatever audience it was. Pretty substantial applause, and politicians like applause. So a few speeches later, he starts saying, I'm going to mention this earlier in the speech. Soon he starts saying that's something we ought to look at, but something I support. That we really need it, because support grows when people talk about it. I mean, Bernie Sanders had no chance. He's not even a Democrat, and he came in and almost beat Hillary Clinton. He was in the lead until a week before he dropped out of this one. And why? Because he's talking about things like this that people say, why don't we talk about that? And the main reason we as Democrats are scared of it is we might lose elections. And I keep thinking, we've been losing a lot of elections anyway. Maybe we ought to stand for something that makes sense.
So you kind of are alluding to this, and I'm going to ask you one last question, and then we've got about 6 minutes left.
Okay.
So we'll wrap it up. But what should this group of people do to kind of push this through, or push through big changes like this that we all are wanting in the community?
Good. First of all, I make the pitch, we have the courage of our convictions. You cannot win. I've been in the legislature more years than I can imagine. I think of it as being 10 years. It's 33 now. And I've had a lot of bills like this one that didn't have a chance. Marriage equality one, I'd say back in 2005 or 6, got people saying nasty things about my support for that. It didn't have a chance. And somehow things changed. I've carried so many bills over the years that when I started pushing, we would have been the first state in the country, benefit corporations, 0.08 on DWI laws. I introduced them before any other state had them. I couldn't get them through and eventually got them through. And in a lot of those cases, we were one of the later states to get them. And things change. So one, believe in what you can. We can change things. And sometimes it doesn't tie directly to it, but sometimes the worst times are, the better your chances are. Social Security, again, if we progressives were in charge in the 1930s, we would have fought for Social Security. We need it for seniors and for people with disabilities. We need to give them health care. We need to give them Social Security benefits. And what would we have done? Well, we're in the middle of a depression. We can't afford to take care of seniors now. Why don't we try a pilot program with 500 people per state? We'll give them Social Security. So believe in what you want and fight for it. Doesn't mean you don't fight for incremental changes. While I've been fighting for this, I also supported the Affordable Care Act as a step forward because it covered more people. You work on incremental changes. You work on insulin for all, which we passed a couple weeks ago. You work for those things and you can change the world. But you also have to work on the big change and shouldn't be ashamed of it, and we got to stand for it. That's item one. Item two, work with others. Indivisible has been an incredible gift to the country since Trump inauguration. But there are lots of other groups. Physicians for a National Health Plan, I mentioned earlier. They have a good group in Minnesota. It's mainly physicians and advanced practice nurses and medical professionals, but anybody can join, and you can certainly get their newsletters and stuff and advocate with them. Minnesota Nurses Association is one of the most powerful groups in Minnesota that supports single payer. They got the entire labor movement nationally and in Minnesota to sign on to at least supporting single payer healthcare, Minnesota Health Plan and Medicare for All. And then there's a group called Healthcare for All Minnesota that advocates for this. I'd encourage you to Healthcare for All Minnesota. Yeah, I'm not sure what their webpage address is, but you can Google them. I'd encourage you to work with them and talk to the legislators. Sometimes you got to elect new legislators there, which we're hoping you can pull off, Renee. But we have to do that. We have to change legislators, but talk to the ones we have as well. And talk to people on Facebook, talk to people with Letters to the Editor, talk to people at work about why it doesn't make sense to have a healthcare system that covers 90%, especially when it costs us twice as much. So, yeah.
Well, wonderful. Well, thank you very, very much. This was very enlightening. I know we had over 30 people. I see a few people clapping.
Oh, thank you. Thank you all. I hope it was helpful. And if you ever do need to, feel free to get in touch with my office. We're not in the office now, but we are. I spend most of my days in front of a computer. I'm wearing a coat and tie, not because I use this for every Zoom meeting, but because we had floor session today. So I had to be dressed up at the Capitol, and I didn't get home in time to change. So.
Oh, well, we made you uncomfortable for the evening, but.
No, this is fun. I wish you all the best and wish you the best. This year's, I think truly this is the most important election in our lifetime. And I really hope that we can see change. I think we have to, for the sake of our democracy, we have to change what's going on in the White House. But I really think we can.
Wonderful. Well, thank you
so much.
Thank you.
Thank
you all very
Yes.
much. Have a great evening and keep in touch.
Yeah.
Good luck.
Thank you very much.
Good night. Goodbye.
Bye-bye.
Bye.
Okay, I think if people would have other questions for Senator Marty, that, we could compile those and we could send them to him. Or maybe you have the answers, I don't know. So, good meeting. Any other last remarks or thoughts or comments? Otherwise, June 8th is our next meeting. And then next Monday is, I'm drawing a blank, Lanny.
Just continuing the exploration of the healthcare system.
Okay, so you can just Zoom every Monday night for the next couple and it'll be good. Okay, take care, everybody.
Good night.
After Senator Marty, that'll be a hard act to follow.
Yeah, that's all right. That's okay. We do what we can do. All right, good night, everybody.
Good night.
Good night.